What's going on, guys? I'm back with another video. Today we're going to be looking at the nephritic syndromes. So all of the different nephritic syndromes that are kind of encompassed. So you're going to see various causes of what's called nephritic syndrome. And then we're going to compare looking at nephritic syndrome versus nephrotic syndrome. And of course, like all of my videos, I supply mnemonics for every specific subtype of nephritic syndrome to help you to remember some of these key details that are really difficult to remember kind of when you go over in a question stem or whatever, where they begin to confuse you at looking at the histology, looking at the patient, kind of the subtype of patient or the past medical history to kind of hint you towards which specific type of nephritic syndrome that it is. So let's move right into this. We're going to start by looking at the differences between nephritic and nephrotic syndrome. So the key details of nephritic syndrome is going to be basically all based around inflammation. So basically, when you compare nephritic syndrome to nephrotic syndrome, these are basically kidney disorders that kind of all have general characteristics depending on whether it's nephritic or nephrotic syndrome. And if you just look at the two words, and this is in first aid as well, the only difference in the two words is the I here and the O here. So the I in nephritic and the O in nephrotic. So just think that the I stands for inflammation. And then the O in nephrotic is going to actually stand for protein loss. Now, there's a couple important characteristics I want to talk about where you may be confused. For nephritic syndrome, the reason that there's inflammation present in this type and that inflammation is then leading to a decreased GFR and basically a loss of kidney function is because there's three layers in the glomerulus as you're leaving, and it's called the filtration membrane. So if this is our glomerulus, as blood enters from the afferent arteriole, right? And then, of course, blood leaves over here from the efferent. And then all of the substrates that are able to be filtered into the nephron would go out through here. There's something called a filtration membrane, and there's three portions of that. So the first layer that the substrates that are leaving the blood will be introduced to is the endothelial cells. So that's these. These are the endothelial cells. After the endothelial cells, you have a glomerular basement membrane. So that's kind of easy. It's just a basement membrane that's in the glomerulus. And then outside of that, you have the formation of something called podocytes, which are like foot-like processes. And they're formed by these epithelial cells that sit out here, and they branch outward and form these podocytes. And there's little openings, see all these openings in between the podocytes, and those are slits. They just call them podocyte slits, and that's what allows certain things to pass through and certain things to not pass through, depending on the size of the substrate. So each one of these, the three portions of this filtration membrane, allows certain things in and doesn't allow certain things in. And it depends on the size, the space in between the endothelial cells, or if it were to enter in through the endothelial cell. And it also depends on the charge of the glomerular basement membrane. So there's a charge of that membrane that repels certain proteins and whatnot. And then the podocytes, the space between each podocyte, which is called the podocyte slits, that will then separate and stop certain things of various sizes from passing through. So I said all that to say that when you look at nephritic syndrome, which is going to be our focus for today, the nephritic syndrome is actually all based off of, you could base it off of damage to the glomerular basement membrane. So let me clear all of this. Let's go back to our filtration membrane. We have the endothelial cells. We have our basement membrane, which is this space here. And then we have the podocytes with the spaces in between called the slits. If you imagine that any damage at the upper part of the filtration membrane, in other words, the part of the filtration membrane that involves the glomerular basement membrane or the endothelial cells, you have to imagine that blood is all in here, coming in from the afferent arteriole and then leaving out through the efferent arteriole. If you were to damage these upper portions that would eventually affect the endothelial cell, you're going to have blood exposed to that direct basically direct exposure of blood to that section. That's going to send off an inflammatory cascade. That's the reason that you have inflammation in nephritic syndromes, but not in nephrotic syndromes. You don't have inflammation in nephrotic syndromes because the damage is lower down in the filtration membrane. So it primarily is involved with podocyte damage or podocyte alteration in nephrotic syndrome, but the blood, it doesn't come in contact with that alteration or damage. That's why inflammation is present only in the nephritic syndrome. So it's highlighted by inflammation. That's what causes the decreased GFR. Now, when you have inflammation that is basically in contact with blood, naturally, blood will leak through because blood is making direct contact with the part that's damaged, the upper part of the filtration membrane. So you will have hematuria. That's not present in the nephrotic syndrome, that's only present in the nephritic syndrome. We talked about damage to the GBM, which I described to you. You have something also called RBC cast. What that means is that, I'm going to draw another glomerulus here. If there were to be damage, let's say, to the glomerular basement membrane, whether it's via messing up the charge that would normally repel proteins or whatever it may be away, or just damage to the glomerular basement membrane. So here's our endothelial cells, here's the basement membrane, and then here's the podocytes. If you damage this and say that you cut this open, so this part is opened, RBCs would maybe be able to go in through that hole. But the thing is, when it goes in, because of the hydrostatic pressure pushing it down, the RBC that would fit through the hole, sometimes maybe more than one can fit. Maybe there's a couple and they all get forced through, and they kind of make a cast. They all get smashed together and they all form this pattern of RBCs all clustered together. That's called an RBC cast. That is diagnostic. When you see RBC cast, you need to always think of glomerular damage. In other words, if the question is trying to figure out what pathological problem this is and they tell you it's an RBC cast, well, naturally you're thinking of nephritic syndrome, but you know that the damage is at the glomerular level, specifically in the filtration membrane. So that's a hint that if they're trying to tell you, oh, maybe there's something, maybe the options are, is the damage at the nephron? Is the damage in the tubules? Is the damage wherever? No, the damage is in the glomerulus because that's what forms this RBC cast when it smashes through the damaged glomerular basement membrane or the damaged endothelial cells. Another very important point, the last point on this list, proteinuria less than 3.5 grams. Now you may be thinking, but I thought you said in nephrotic syndrome, that is highlighted by proteinuria or protein in the urine. You can actually have protein loss in nephritic syndrome as well, but it will be less than 3.5 grams per day. So that's super important to know. So a lot of times when I'm looking at the answer choices, the first thing I do is I go back into the question stem and I look at how much protein loss was recorded in the patient's urine per day. If it's less than 3.5 grams, it's not technically considered a nephrotic syndrome. Now, you can have situations where you have a protein loss of greater than 3.5 grams per day. So you may automatically think, well, this is a nephrotic syndrome. But then you read the rest of the question stem and the patient says that there's hematuria. Well, that's only in nephritic syndrome. So that is a situation of a nephrotic and nephritic syndrome mixed. So it's called a mixed, basically nephrotic. You can see it's either called a mixed kidney disorder or it's a mixed nephrotic disorder. And there are two examples of that, but we're not going to go into too much detail on that. I have a separate video on the main type of a mixed nephritic disorder, and that's membranoproliferative glomerulonephritis. But we're not going to get too much into that. So these are the characteristics that define a nephritic syndrome, which is going to be the focus of today. Now, these are the nephrotic syndrome characteristics. I'm going to quickly read through them, but I'm not going to explain it because that will be in the next video. Nephrotic syndrome is damage to podocytes. I kind of already talked about that, the lower part of the filtration membrane farther away from the blood. Proteinuria greater than 3.5 grams per day. There's no hematuria. Hyperlipidemia. I'm going to explain that in another video why that occurs. Decreased antithrombin 3. That's because we're having high protein loss greater than 3.5 grams per day. And antithrombin 3 is a protein, so naturally you could have a hypercoagulable state. Then fatty cas and maltese crossing. That's all of this stuff's going to be explained in the next video. Let's jump into the kind of the more substance-based part of nephritic syndrome. The causes of nephritic syndrome. So this is where it's hard. Everything kind of makes sense, but it's difficult to remember all of the details, and that's where I'm hoping I can help you. If you've watched any of my videos, you know I use mnemonics for everything. It helps me to remember all of the hundreds of facts that you have to know while going through medical school or whatever it may be. So this is a mnemonic that I have developed. This is the ABCs of nephritic syndrome. If you look at the causes of nephritic syndrome, you will see that all of these go exactly like the alphabet would go, like A, B, C, D. The only thing is that there's 2 causes for A, so just remember that. So the ABCs of nephritic syndrome. You have acute poststrep glomerulonephritis, Alport Syndrome, Berger disease, also called IgA nephropathy, crescentic glomerulonephritis, also called rapidly progressive glomerulonephritis, and then diffuse proliferative glomerulonephritis, also goes by DPGN. These are going to be the things that we're going to talk about in this order today on this video, and there's going to be mnemonics for all of these to remember the important details. So let's move right into it. The first one, Poststrep glomerulonephritis. I want you, the key to this mnemonic is to really just look at the word. So we have acute poststrep glomerulonephritis. That tells you a lot. And then I've added in a little mnemonic to get the rest of this. First of all, you have to know, look at this right here in the word, acute poststrep. It's telling you that this glomerulonephritis, this nephritic syndrome, this inflammatory nephritic syndrome is happening post-strep. So if you think of what, like strep throat or some, caused by strep pyogenes, right? Strep pyogenes causes strep throat. But don't forget that strep pyogenes can also cause impetigo, which is a skin infection, so they could try to trick you in that manner. But just know any cause of strep pyogenes can technically lead to this acute post-strep glomerulonephritis, this particular type of nephritic syndrome. Now here's where the mnemonic comes in. The first one, when you look at this word, I want you to look at the P in it, and instead of pronouncing it as acute post-strep glomerulonephritis, I want you to say either one of these 2 things. They both have a part of the mnemonic. Acute plenty strep glomerulonephritis or acute partial strep glomerulonephritis. Use them both. For the first one, see, because they both start with P's. So just kind of get used to saying that. It will give you a lot of answers for various parts of the histology that's kind of complex to remember. The first part, the P. P for plenty. Plenty is telling you the immunofluorescence stain, what components are causing that immunofluorescence stain. So if you've done any studying on this, you can do immunofluorescent staining. So they send a dye through the kidney, and then that dye is basically causing, when you put it under like a immunofluorescent light, like a black light, it will cause it to light up like a bright neon green if those particular components or deposits are within the kidney. And there are patterns of IF staining, immunofluorescent staining. The 3 main ones important for nephritic and nephrotic syndrome, the first one is linear, the next one is granular, and the last one is called palsy immune. That just means it's not staining at all. It's just a fancy way of saying the stain is not connecting to anything. So palsy, when you look at palsy immune, paucity is like a paucity or a pause. So basically there's nothing there. You have an absence of immunity for immunofluorescent stain. Now, what do each of these mean? Linear stain means that when you look at the immunofluorescent stain and for the particular patient of their glomerulus, for example, you'll see that the neon green stain will stain the deposits, say the different histology of the glomerulus. It will be a continuous stain around the entire portions of the kidney. There will be no dotting of the stain. There will be not an absence of the stain. The staining goes all the way around the various components of the kidney, within the kidney glomerulus. That's called linear. So linear for line. Like a line can be linear. So think L, think line. It makes a solid line. Because, when you think of a line doesn't go like this. A line is this. So that is what it's going to look like and I have pictures for all of this, so I'll show you later on. The next one's granular. The granular one is this one that I described. Think of granules, like salt granules. It's like a bunch of little dotted, lumpy things. And when you look at the immunofluorescent stain, the glomerulus will light up neon green in this granular pattern. And then the last one, Immune, you'll put it under a immunofluorescent stain and you'll look at it under a black light or whatever it may be, and there'll be no neon green anywhere in it, or just small amounts. That's called Immune. So it's not, there's nothing there to stain that for that particular immunofluorescent stain. Now, it would be nice if the test question stopped there. But a lot of times they want to know for a particular important type of nephritic or nephrotic syndrome, what is the component, what is the immunofluorescent stain actually staining in that particular disease? That's why this mnemonic's important. Acute plenty strep glomerulonephritis. Plenty tells you there are plentiful cell types, we could say that, and protein types. When you think of plentiful, you think of all of them. So what is all of them? IgM, IgG, C3. C3, remember, is the particular type of complement protein. So it has IgM, IgG, and C3. Now, it doesn't have IgA. I know you may be thinking you can also have IgA staining for immunofluorescence. It doesn't have IgA, but that's kind of easy to remember because there is a particular nephritic syndrome that only involves IgA, and it's literally in the title. So that's how I'm able to remember IgA is not included in this plenty mnemonic. The next one. Now we've remembered that P was for plenty. Also think P is for partial. Partial is telling you what type of staining it'll have. When you put it under immunofluorescence, this particular disease, acute Poststrep glomerulonephritis, will have a granular immunofluorescence stain. It's how does that relate to partial? Because if something is partially stained, that means it's not going to be a solid line like it would in linear. It's going to be kind of dotted or every now and then. That's called a granular stain. So that helps you remember. So P for plentiful, that's telling you it has IgM, IgG, C3, and P for partial IF staining or granular immunofluorescent staining. Now, what is Poststrep glomerulonephritis? It is a nephritic syndrome that happens primarily in children, and it happens about anywhere from like 2 to 4 weeks after a strep pyogenes infection. So you could have strep throat, which is just pharyngitis. You could have a skin infection caused by strep pyogenes like impetigo. And then 2 to 4 weeks after, all of a sudden they're having a decrease in their GFR, their BUN and creatinine is starting to go up. And that should really help you to begin to think, okay, this patient could have acute Poststrep glomerulonephritis. So Poststrep only happens post-strep pyogenes, so no recurring symptoms. So this is basically saying, this is a really important fact here. I'm going to explain why. You have to remember that this disease only shows up after a strep pyogenes infection. So it is not going to be recurring symptoms. It's not like you have this disease now, it just seems to happen all the time from a trigger or whatever. You get this strep pyogenes infection, and then afterwards you have an acute bout of this particular disease. Now that is in comparison to Berger disease, which is coming up. This is also known as IgA nephropathy. This is the one I was telling you earlier, how I'm able to remember that IgA is not involved in the staining of Poststrep glomerulonephritis, because it's literally the other name for this disease, Berger disease. The reason that it's important to know that this is not recurring is because in IgA nephropathy, if you remember what IgA does, your immunoglobulin A is at mucosal surfaces. So think in your mouth, in your GI tract, wherever there's a mucosa, in your nose, whatever it may be. And this IgA is responsible for destroying the disease before it gets into your body, whatever it may be. Bacterial infection, it doesn't matter. So that means anytime you're exposed with an infectious agent, like a pathogen or whatever it may be, that means anytime you're exposed, if you have an IgA nephropathy, you will see the symptoms of IgA nephropathy, which is a particular type of nephritic syndrome, every single time you have a mucosal pathogen that's trying to get into your body and make you sick. So if you had a GI infection, your IgA nephropathy would act up. If you had something get into your nose, like a bacteria or whatever that you inhaled, your IgA nephropathy would act up if the IgA was beginning to attack it. So that is recurrent, whereas post-strep, you would see one particular case after a strep infection. So they'll try to trick you on this. So if you see recurring symptoms after an infection, think more of Berger disease and not post-strep glomerulonephritis. Plus, post-strep glomerulonephritis, this is another really important, let me clear all this to make it cleaner. Post-strep happens, I said, about 2 to 4 weeks after a strep infection. But look at the comparison. With IgA nephropathy, it takes only days. And because it only takes days, sometimes sicknesses naturally go longer than some days. So that means a lot of times you could have the symptoms of IgA nephropathy while you are still having whether it be the GI infection or the nasal infection. But in strep, the strep would have been long cleared before you would then have kidney problems. So that's how in question stems, if you're seeing that the patient is having decrease in GFR and problems with their kidney during the disease, you need to think more of IgA nephropathy. But in acute post-strep glomerulonephritis, they would have been sick 2 to 4 weeks, let's say, prior, and then all of a sudden they're having kidney issues, but the disease isn't present. So think of that timeline in distinguishing these two diseases. Now, here's the difficult stuff that's hard to remember. Most medical students, nursing students, whatever, can remember this stuff. You can kind of remember what the disease is. This may be a little harder to remember, but I gave you a mnemonic for it. Most medical students remember it's a granular IF staining. The hard part is the electron microscopy changes, the light microscopy changes for all the different diseases. This particular disease shows up as something called subepithelial humps. You will see that is a buzzword. And you may think it's extremely hard to remember that, but this is what I think. In patients with strep throat, basically just say it like this: subepithelial humps, think subepithelium hurts. So strep throat is extremely painful. It's extremely painful just at rest, really, really painful when you swallow. You can imagine that your epithelium and your subepithelium of your throat is hurting and it's inflamed. Subepithelium hurts sounds a lot like subepithelial humps. So sore throat hurts, that's indication, oh yeah, we're talking about post-strep glomerulonephritis. So that's the way that I remember those EM changes for that one. Now, let's actually look at a picture. Sometimes they won't give you the word subepithelial humps in a question. They'll just show you a picture. In this particular picture, you can see it right here. Now, I want to begin to separate the different parts. For me, whenever I look at a picture of kidney histology, I always find the glomerular basement membrane. It's the easiest thing to find, and it's right here. There's the glomerular basement membrane, and here are these subepithelial humps pointed to by these white arrows. Notice how large they are, and also notice that in between it, you don't see much deposit in between it. They are very distinguished and discrete from each other. These are called subepithelial humps. Don't forget these facts. They're very large, and there's no deposits in between them. That's going to come to be important later on. I'm going to show you in one of the other nephritic syndromes that we're going to talk about. These are called subepithelial humps. Okay, so in other words, what does sub mean? Sub means underneath. So let's go back to our filtration membrane. These are your endothelial cells. This is your glomerular basement membrane, which is extremely easy to find on the picture. That's the thing I always use as a reference point. And then you have your podocytes. So in this one, it's telling you subepithelial. That means it's underneath the podocytes. And that's what you can see right over here, subepithelial humps. Underneath the podocytes, which means it's basically it looks like it's attached to the glomerular basement membrane, because that's what's underneath the podocytes, subepithelial humps. And what's the mnemonic for it? It's subepithelium hurts. Think of your subepithelium of your pharynx, or your throat, hurting when you have sore throat. That will help you to remember. Next one, Alport Syndrome. This is the other A. Remember our mnemonic, the ABCs of nephritic syndrome. There's 2 A's, and then it goes AA, B, C, D. That's the nephritic syndrome causes. So Alport Syndrome. Alport Syndrome is just a defect in collagen type 4. Remember that whenever you see collagen type 4, it's always dealing with basement membranes. Specifically, it's a defect in alpha 345. Now, it's maybe important to remember that, but I think it's more important just to know that it's affecting the alpha subunits, and it's affecting a bunch of them. 345, I guess you could remember that, but I don't think it's as high yield as maybe it would be. Definitely, you have to remember collagen type 4 defect. Now, and I've already said type 4 is always involved with basement membranes. Now, there is a mnemonic for this one, and I don't really like it, and I'm going to explain why. In the first aid book, the mnemonic is can't see, can't pee, can't hear a bee. That sounds, if you're a medical student, you know what that sounds very similar to. It sounds very similar to reactive arthritis mnemonic. In reactive arthritis mnemonic, it is can't see, can't pee, can't climb a tree. But in this one, it's can't see, can't pee, can't hear a bee. The reason I don't like really any of these mnemonics is because, okay, that's a very clever mnemonic, but you have to then remember that that mnemonic goes for that disease out of the thousands of diseases you have to learn about in medical school. I prefer this mnemonic, which makes more intuitive sense and can link you to, oh yeah, we're talking about Alport syndrome. First of all, Alport sounds like airplane or like airport, right? So let's just say airplane syndrome. It even looks like that. Airplane syndrome. And on an airplane, the bathroom always has a line. Anytime I've ever flown, the bathroom is always busy, and a lot of times there's people waiting to go to the bathroom. So that then correlates to this can't pee part. They're not going to be able to pee very well in Alport syndrome. And the next part, on an airplane, you can't hear anything. The jet engines are so loud, your ears will pop and they'll be closed and you can't hardly hear anything on a plane. That's literally hinting on this point, can't hear a bee. So that takes care of the hearing part. And the last one, you can't see the ground. So when you're up in the air on an airplane, you can't see anything but basically clouds. So you can't see anything, and that will help you to remember you can't see. So all of that just thinking through what happens on an airplane will help you remember the symptoms versus remembering something that would probably get you mixed up with reactive arthritis mnemonic. So that's why I prefer the one that I've thought of there in red. Now, the last one. There is something on electron microscopy that is a certain pattern. First of all, you have a thickened glomerular basement membrane in this disease, but that happens in a lot of nephritic and nephrotic syndromes. But it has this particular pattern, and it's described in word form a lot as a basket weaving appearance. So I think of this. A grandmother is flying on an airplane and she's bored and she's weaving a little basket. I think of a cute little grandmother with white hair and she's weaving a basket, and that kind of helps me remember, okay, she's super bored, it's a long flight, so we have a basket weaving appearance on electron microscopy. Now, I've heard other friends, they tell me that because Alport syndrome starts with an A, they can just then remember, oh yeah, we're going to go as if we're going with the alphabet again. B is then for basket weaving, but I prefer the grandmother one. It's easier for me to remember, but whatever works for you is fine. Let's now look at the electron microscopy. I just put this on the side to show you what a basket looks like. Basket weaving pattern is this. It's basically a pattern of you doing this. That's all it is. Basket weaving. Up and then down. Up, down. Now, here I'm going to show you why it's important to know how this looks on electron microscopy. The top image is showing a situation of a patient. I'm going to zoom in actually to show you this better. Let me find the zoom in so I can really show you. Look at this. The top image here is showing the glomerular basement membrane, which is very easy to recognize. It's where that little like a triangle arrow is pointing to, and it's that large gray area. Now, the bottom area down here is showing also the glomerular basement membrane, but I want you to compare the two. In the top one, you see how smooth and it's all entirely gray. There's no lines going through or anything. It just looks like you took a gray crayon and smoothly colored the whole glomerular basement membrane. Look at the bottom picture. They're both thickened glomerular basement membranes. Keep that in mind. They're both thick. Look at the bottom one. The bottom one shows, you see all these lines and stuff through it? I'm going to actually zoom back out now. Get back to my pen. In this bottom one, you see all these lines going various directions. Look down here at the bottom. See all these lines doing this and going all different ways through the glomerular basement membrane? Now, they're both thickened. But in this particular one on the top, it's not Alport syndrome because it doesn't have the basket weaving pattern. In the bottom one is Alport syndrome because it has a thickened basement membrane and it's a basket weaving pattern. Don't mix that up because a lot of nephritic and nephrotic, especially nephrotic syndromes, have a thickened basement membrane, but they don't have this basket weaving pattern. See how it's just a normal contour, smooth contour all the way through. In the bottom one, there's lines going all over the place. That's called the basket weaving pattern, and it's fairly diagnostic for Alport syndrome. Next one, Berger disease. I kind of mentioned this earlier. This is another name. This can go by either name, so you have to memorize both. Berger disease, and also known as IgA nephropathy. I see this more often in questions. This is a renal mesangial cell specific HenochOnline Purpura. Okay, what does that mean? I want to remind you that HenochOnline Purpura is the same exact thing as IgA nephropathy, except it is an IgA. They're both IgA vasculitis. You could say vasculitis, or HSP is an issue with IgA overactivation. But in HSP, it is all over the body. It's basically systemic IgA. So you'll see changes on their skin of their lower legs and on their upper torso and all that kind of stuff. You'll see palpable purpura, and you'll see tons of other organs are affected in HSP. Now, in Berger disease or IgA nephropathy, it is specifically only affecting the kidney. So it's the same exact thing as HSP, except it's only affecting the kidney, and that's called IgA nephropathy or Berger disease. So it's less severe, you could say, than HSP, just has an absence of the kidney issues. That kidney-specific issues is all you would see in IgA nephropathy. Now, it says here, let me clear this. It says here that it's renal mesangiocele specific. We need to know what a mesangiocele is. In the kidney, in the glomerulus, you have basically various cells that are kind of present, kind of more in the middle of the kidney. I know I'm simplifying this a lot, but I don't want to go into too much detail. Before you get to the tubule and kind of towards into the nephron and then go into the proximal convoluted tubule and the loop of Henle and all that, there are these Mesangio cells that make up around where the renal corpuscle is. And these cells are what is going to be basically affected in this disease and targeted. So this is a nephritic syndrome that targets renal mesangial cells, and it is it's a kidney-specific form of HenochOnline Purpura, because HenochOnline Purpura is a body-wide IgA vasculitis. Okay, so I said all that to now we can go through the rest of this. This occurs days after or concurrently with a respiratory or a GI tract infection. Now remember, I explained to you earlier what IgA does. IgA is sitting in large quantities at mucosal surfaces, like inside your nose, in the GI tract, kind of in your throat, some in your throat and mouth. Anytime you get infection, you have an issue with IgA overactivation and it causes inflammation at the Mesangio cells specifically in the kidney. So this is recurring. Now, we compared IgA nephropathy earlier in the video to acute Poststrep glomerulonephritis, and I said that in acute Poststrep, you get Poststrep 2 to 4 weeks later, you would then have the symptoms of the glomerular inflammation and all the issues that come with that. In this one, you can have a patient will present to the clinic and they'll have a ton of this will happen multiple times to them. Every time they have a mucosal infection, they most likely will have some issue with this. So this is important to know, it's episodic. That is in comparison to acute post-strep glomerulonephritis, which will happen just after they have 2 to 4 weeks after. Also important to note, it can happen days after, not weeks, like an acute post-strep the acute post-strep nephritic syndrome. It can happen days after or concurrently, because a lot of times when you get sick or you get an infection, the infection can go longer than just a couple days. So a lot of times you will still have the respiratory or GI tract infection and concurrently have the kidney issues, the decreased GFR, inflammation, all that comes with this. Now, here's what's going to happen on light microscopy and on electron microscopy. So that was a terrible line. Let me just clear all this. And so basically we're talking about this point. I told you already this is affecting Mesangio cells, and it's causing Mesangio cell proliferation on light microscopy, and then it's causing immune complex deposit on electron microscopy. So in other words, on electron microscopy, when you're more zoomed in, you begin to see the immune complexes kind of at the area of the Mesangio cells. Whereas if you're just looking like via light microscopy with H&E stain, you will only see you'll just be able to notice that there is really large amounts of Mesangio cells that have hyperproliferated. When you zoom in further, you begin to see the deposits. And what are the deposits going to be made of? It's going to be made of IgA, right? Because it's literally in the title of the disease, IgA. How I remember this? I think of this. Berger disease, think of a hamburger, right? A burger. You're eating a burger somewhere. Here's a little burger. And the burger itself, the hamburger, is inside the actual bun, and it's in the middle of the thing, right? It's in the middle. Well, mesangial cells, when you look at like a histology slide, the mesangial cells are all clustered in the middle. They're not on the periphery. When you look at an LM slide, you're going to see all of the deposits and the hyperproliferation of mesangial cells are all in the middle of these units. That helps me to remember, okay, when I look at burger disease, I think of a hamburger, and that's in the middle of the sandwich. So we're dealing with mesangial cells. So you could think it's in the middle. You can also think M for middle, mesangial for middle. So we're having proliferation of those middle cells, the mesangial cells. And when you zoom in further, you're going to see immune complex deposit at these mesangial cells. Okay, let's look at a picture. Here's a pretty complex picture, but I just wanted to show you where the mesangial cells are. Do you see how the mesangial cells are before, more in the middle of this whole? If you were to look at an LM slide of this, a light microscopy slide, all the mesangial cells are clustered kind of in the middle before the glomerular capillary. See, because all of these cells here that are actually in the glomerular capillary are the endothelial cells, the first part of the filtration membrane. But in this picture, the mesangial cells come before, right as the afferent arteriole is bringing blood. It's kind of those initial cells that it will enter before the glomerular capillary. Okay, so those are the mesangial cells, and notice they're all in the middle of this whole renal corpuscle unit that I have told you already. Now, here's what that is, just a general drawing. I've explained all that to now look at the next picture. Do you see? Look at how all of the deposits are clustered here where the mesangial cells would have been. That is basically, this picture is very easy to recognize because all of the immune complex deposits are in the middle of the thing. So middle, you'll remember if you think of a hamburger, that is the burger's in the middle, so that's a mesangial cell immune complex deposit. Okay, so that's how I remember that. Next, crescentic glomerulonephropathy. This is also called rapidly progressive glomerulonephritis, and you need to know it by both names. If you can remember, it's literally telling you, both of them kind of gives you keys to what's going on. I'm going to walk you through all of it. Okay, we're going to use the first part of this, we're going to use the rapidly progressive glomerulonephritis to kind of get an idea of what's going on. Basically, rapidly progressive glomerulonephritis, or RPGN, is exactly what it sounds like. It is a nephritic syndrome that is now rapidly progressing. So it's very severe. Rapidly progressive means it must have progressed from something, so it comes about from other glomerulonephropathies or conditions. Something that is rapidly progressive means that there had to have been something there to rapidly progress from. So this is a particular type of nephritic syndrome that typically comes from other conditions or other nephritic syndromes. And then it enters into this rapidly progressive glomerulonephritis, and it's far more dangerous when you have this. So you can get this from a lot of various nephritic situations. You can get this from other diseases. And the main important thing to know from this is what you're going to see when you look at a light microscopy image, and it's literally in one of the names of it. You're going to see Crescent, and I'm going to show you a picture. And then it's important to know this. The cause of rapidly progressive glomerulonephritis. So I had told you that a lot of times these can start from nephritic syndromes, but a lot of times they can start from other diseases, other causes, or whatever it may be. And the test people who write the questions of the test will expect you to know what is actually causing. So they'll show you a picture, for example, and they'll show you, this is a light microscopy, and they'll show you crescent kind of fibrosis and damage. So all of this is like a glomerulus, right? And all of this is colored in. This is all fibrotic. So you're thinking, oh, that looks like a crescent shape. This must be crescentic glomerulonephropathy, also called rapidly progressive glomerulonephritis. So then, but that's not enough to know that. Then they'll show you an immunofluorescence stain. We talked about this earlier. The immunofluorescence stains, linear, granular, and pulsi-immune. There's other types, but these are the important ones for the nephritic syndromes. And then, according to which of those it is, will tell you what the cause of this, what caused this crescentic glomerulonephropathy, this severe form of nephritic syndrome that has happened in the patient. Now, here are my mnemonics for that. If you have a linear immunofluorescence, remember that means that you're having a complete immunofluorescence around all of the structures of the kidney. There is no granules. There's not an absence of anything. It's completely covering the structures on LM of the kidney. Then that is going to be a cause, typically, I'm saying, the cause is then going to be good pastures. Good pastures. So if you see a situation of rapidly progressive glomerulonephritis, you were able to recognize it by kind of the description of the patient, plus they showed you a crescent in the kidney. And then they put in it later on in the question, they either tell you the immunofluorescent stain is linear or they show you in a picture. You need to think it's caused, then that means the crescentic glomerulonephropathy was caused by good pastures. Now, how do you remember that? Just looking at the word, there's an L in linear, right? So the three types: linear, granular, pauciimmune. There's only one of them that starts with an L. L for linear. And remember, that's also L for line. That helps you remember what it looks like on immunofluorescence. Well, the L is shaped like lungs. This is the way I've always, not only shaped like lungs, literally L for lungs, right? L. So linear for lungs. They both start with an L. But in good pastures, you're having hemoptysis, so that's coming from the lung damage, plus you're having kidney issues. If you were to, you can pull up this on Google and look at this. When you look at your lungs, they kind of have that curve like this. They kind of look like that in your chest. When you look at lungs kind of head on looking at the patient. And then if you look at kidneys, which are more towards the back and lower, you'll see that they have that same kind of curved, this kind of thing going on. They both make an L shape to them. So anytime I see that linear, I always kind of think that kidneys and lungs kind of look similar, except there's a size discrepancy and a location difference. So that helps me remember. L for linear, and L for line, and then L for lungs and kidneys, because they're shaped like this L in linear. So that will help you remember good pasture syndrome. Next, granular. Now, I had already told you, granular, the cause is granular immunofluorescence nephritic syndromes. We talked about one of them already. We haven't talked about diffuse proliferative, but we're going to get to it. But I had already explained to you that the way you can remember that acute poststrep glomerulonephritis is granular is by saying acute partial. Remember? P for, instead of saying acute post, say acute partial strep glomerulonephritis, right? And partial will tell you, oh yeah, we're having a partial IF stain. So it's not all of the kidney that stain, it's just some of it. So maybe dots and little spots here. That is a granular immunofluorescence stain, and that's signature for this particular nephritic syndrome. Now, there's another nephritic syndrome that has this granular pattern along with some other ones as well. Diffuse proliferative that we're going to talk about later. But basically, I said all that to say, if you see a granular pattern, you know it's caused by, it was a nephritic syndrome that caused it. It was one of these nephritic syndromes. So you need to be thinking, oh yeah, they had a previous nephritic syndrome and that it intensified to this rapidly progressive type. And that's if you have a granular immunofluorescence stain associated with it. The last one is pauciimmune. Remember I said P is for pause, like stopping something. So you're stopping the immune response. So you don't have any stain. So you put the IF stain into their body, it goes to the kidneys, nothing stains, that neon green color. If that happens, vasculitis is the cause. How do you remember that? Well, first of all, vasculitis is affecting your vessels, and I think of it's kind of body-wide in all your vessels, so it's not specifically involving any particular area, it's body-wide. So that helps me remember that if it's pauciimmune and you have no staining, it's telling you that this is not specific to the renal area in any sort of way. It's kind of everywhere, right? So it's not specifically targeting the kidney, therefore you won't have an immunofluorescent stain. Whereas in the linear stain, it was specifically targeting the lungs and the kidneys. There's the kidneys. In the granular type, there is some sort of IF stain going on in the kidney. Therefore, we know it's the nephritic syndrome type. But if there's no stain at all, this is not specific to the kidney in any sort of way. Therefore, this is a body-wide vasculitis. That is the way I remember this. a cause typically absent of kidney issues. Okay, so that is very important to know for this RPGN type, the rapidly progressive glomerulonephritis, figuring out what its cause is by IF stain. Okay, now these are a couple practice questions. This is kind of what they're going to show you, and I've seen questions like this. So looking at this immunofluorescence stain, this is showing a segment of a kidney. Look at what's going on. You see how these are all solid lines? Solid lines, no gaps, no nothing, and you're having a stain on the kidney. This is linear. Now that you know that this is linear, what is the possible cause? Good pastures. Remember I said in good pastures, L in linear is for lungs, right? L is for, I don't know what I did right there. L is for lungs. And also, what else is L, has that weird L shape and kind of looks like lungs? Kidneys, of course, because we're talking about the kidney. We're talking about acute nephritic syndrome. So lungs and kidneys are what is affected in good pasture syndrome. So they're going to have hemoptysis and kidney issues. That's good pasture syndrome. Therefore, if they were to end up presenting with a rapidly progressive glomerulonephritis, they're going to have a linear immunofluorescence, and it'll look like this picture. Next, what about this stain? In this particular stain, oops, sorry about that. In this particular stain, do you see these little clusters? You see how it's not, a lot of it has stayed dark, and then you see random areas of neon that's kind of dotted, and then there's some here, and then there's not, and then there's some more, and then there's not. This is granular. Remember what I told you about granular? I taught through, when you think of post-strep glomerulonephritis, I said to think acute partial strep glomerulonephritis because it's partially staining. So that should help you remember, okay, the cause of this is going to be the nephritic syndromes. It's going to be the nephritic syndromes with granular IF, immunofluorescence. So one of those we've already talked about, acute post-strep glomerulonephritis. And then another one is coming up is the diffuse proliferative glomerulonephritis, which we haven't talked about yet, but that also has a granular stain. And then there's also another type, a bunch of them have granular stain. But basically, it's more important to know that what's the cause of RPGN. You need to be thinking of nephritic syndromes, because in the question stem, in the multiple choice, they're going to put a vasculitis. You better believe they're going to put a vasculitis. You better believe they're going to put good pastures. They're going to see how well you know this topic. Okay, next one. Ignore these other pictures, just look at A. If you get this immunofluorescence stain, practically nothing is lit up here. Okay, practically nothing. This is pauci-immune. So this is basically, you're having no staining at all. What's the cause? Vasculitis. How do we remember that? Because this is in no way specific to the kidney. You can't hardly stain anything. You can't hardly find any electron-dense deposits. Therefore, this is a vasculitis that is causing this kidney failure. You're having a lack of any sort of immunofluorescent stained immune complex or whatever it may be that is going to be stained. Okay, so that is that. Here's the last one, DPGN, Diffuse Proliferative Glomerulonephritis. This is the other one that has a granular IF stain, so keep that in mind. This is the other one that has the granular IF stain. Whenever you think of diffuse proliferative glomerulonephritis, you need to think of lupus immediately. It is a lupus nephritis type 4. There is up to 5 types of lupus nephritis. Lupus nephritis is basically, lupus nephritis is basically just inflammation of your kidney because of lupus, and it presents in different ways. So lupus is an autoimmune disease that basically affects anywhere in the body. There's no organ that's immune to lupus. If you were to have kidney issues from lupus, it's then distinguished, it's called lupus nephritis, and there's types 1 through 5. This one particular, DPGN, diffuse proliferative glomerulonephritis, is type 4. That's very important to know. Okay? And just looking at the word, here goes the mnemonic again, diffuse. Diffuse means it's everywhere. It's not localized, it's not focal, it's diffuse. So diffuse means more than 50% of the glomeruli is affected. More than 50% of glomeruli are affected. That's important to know. It's diffuse, it's all over. So if you look at an LM, more than 50% will be affected. Another important characteristics, you will see, now look here, subendothelial deposits of anti-double-stranded DNA. Subendothelial. Let's go back. Let me clear this. Let's go back and talk about how we're going to intuitively make this make sense. we have a filtration membrane. Here's our glomerulus. We have our endothelial cells. That's the one in direct contact with the blood that's coming from the afferent arteriole here. And then the blood drops off its substrates that it doesn't need to be filtered, and then it sends it out to the efferent arteriole. The substrates will go, and the first thing it encounters is the endothelial cells. The next thing it encounters is the glomerular basement membrane, this space right here. The last thing it will encounter is the podocytes, and those little slits in between the podocytes are called, the little podocyte slits. That's what, by size, will separate what can go through there. Okay, so that's our filtration membrane. This particular disease, when you look under EM, you will see subendothelial deposits. Now remember, I discussed earlier that in the acute post-strep glomerulonephritis, you have subepithelial humps. And I said how to remember that. You can remember subepithelial humps by saying my subepithelium hurts, because your subepithelium of your throat would be inflamed and hurting when you have strep throat. In this one, how do you remember it's subendothelial? It's important to notice this doesn't say epithelial. Subendothelial means that now we're having deposits that are right underneath the endothelium. Whereas before we were having subepithelial, those deposits were over here and they were much larger. Now we're having subendothelial deposits. And we're having subendothelial deposits of anti-double-stranded DNA. Do you know why? Because anti-double-stranded DNA, whenever you find that, is always hinting towards lupus. That is highly associated with SLE, another name for lupus. How do you remember it's subendothelial? Because anything that would be that far up, close to the blood flow that's coming, so if this is our glomerulus, here's our afferent, here's our efferent, here's our little, I'm not going to draw it all, but here's our filtration membrane. I said earlier at the beginning of this video that nephritic syndromes have associated inflammation. And I said that the closer that things are, the damage is towards the blood, the more that blood has the ability to make direct contact with the damaged portion or the altered portion, the more inflammation. There's not many diseases that has as high of an inflammatory level than SLE, lupus. It's extremely inflammatory. Your whole body's practically inflamed because of this autoimmune disease that attacks pretty much any tissue or organ that it wants to, that it deems as not part of itself. So that helps me remember that this has to be the disease associated with the subendothelial deposits versus the subepithelial humps that are basically then underneath the epithelial cells. The reason is because it's closer up to the blood. It produces more inflammation. So versus something just as simple as you had a bout of nephritic syndrome after an acute post-strep situation. You had strep throat, then you had acute post-strep glomerulonephritis. That's much more minor than being diagnosed with lupus, that is what causes this DPGN. And then, so that means you would expect far more inflammation in SLE. Therefore, the deposits would be much closer to the blood to elicit a much more higher inflammatory response and thus immune response. So that's how I kind of keep myself in check that, okay, we're dealing with subendothelial deposits, and then this part is easy because this has probably been drilled into your head all of medical school. Anti-double-stranded DNA is associated with SLE. Okay, this is granular, which, like I mentioned in the last disease we talked about. And there's something called hypocomplementemia. I don't really have a way to remember that per se, but just keep in mind that these are the diseases that cause your complement levels to go down. And the reason it causes your complement levels to go down is because it's consuming all of your complement via deposits and using up your complement from the massive inflammation. We talked about one of them, Poststrep glomerulonephritis. Now we're talking about another one, DPGM, Diffuse Proliferative Glomerulonephritis. The last one, membranoproliferative, which we're going to talk about in another video. That's because this is a mixed disorder. It's nephrotic and nephritic. That's why we're talking about that one in another one. All of these are granular. So if you can remember that all of the granular diseases, you'd have a good shot at remembering, okay, then those are also the ones that cause hypocomplementemia. Okay, so that's an easy way to remember that. Now, the last characteristics, you have something called wire looping capillaries. The way I remember this is if you were to write out with our little mnemonic, ABCDs of nephritic syndrome, right? ABCDs of nephritic. We talked about acute post-strep glomerulonephritis. We talked about Alports. We talked about berger's, which is IgA nephropathy. We talked about crescentic or rapidly progressive. Now we're talking about DPGM, diffuse proliferative. In all of these, the only one that looks like a circle is this. A D kind of looks like a circle. Like if you were lazy with it, it kind of looks like a circle. And wire looping, I'm going to show you a picture on histology, it looks a lot like a little thickened circle around the capillaries. It is diagnostic for this disease of DPGN, and that's what you'll see on histology. Here's a picture. I want you to look at these showing an H&E stain of kidney. You're going to see, when you look in here, you see these little circles, these thickened rings around this? This is wire looping of capillaries. These little circles that you see all the way through the kidneys, that's called wire looping, okay? So that's something to keep in mind. These little circles, and you can see them all in the picture. I'm not going to go through and find each one of them. But if they show you this picture and you see all them little circles all throughout the picture, that's wire looping. I want you to remember wire looping is something that's making kind of in a circle or that's closing around it. And it looks a lot like the letter D. That's DPGN, caused primarily by SLE. Okay? I hope this video helped you. I'm pretty sure that's all I have. I supplied a ton of mnemonics. Just if you're still confused, watch the video again, listen to the mnemonics, and see if it helps you. It helped me a ton. The next video is going to be on nephrotic syndrome, and I have some good mnemonics coming for that one as well. I'll hit you up in another video. Bye, guys.